Welcome back, everyone. I'm Lindsay Brown with Beyond Clean. We want to thank 3M for sponsoring this event. And before we get started with the next session, I want to make sure that everyone who is tuned in is aware of all the different features of the event platform. On the right-hand side in the upper right, you'll see a resources list. This is a list of downloadable resources and links put together by session speakers and the conference sponsor. On the lower left, you'll see a question and answer tool. You can submit questions to each speaker during each presentation. They'll be addressed during the question and answer portion at the end of the presentation. Before we get started with this next session, I had the sincere pleasure of sitting down with Kayla Ostrander, a 3M application engineer, to discuss the new 3M A-Test chemical integrator. Take a quick look at our interview.
Kayla, welcome. Thank you so much for sitting down with me and talking about the 3M A-Test chemical integrator. I would love to know a little bit more about you. Tell me a little bit about your background in the industry.
So currently I'm an application engineer here at 3M, but prior to my role here, I was a sterile processing technician and supervisor for 13 years.
Wonderful. So you've had a lot of experience working with various manufacturers' products and really getting into how they work in real-time situations.
Correct.
I am so curious to learn why the color change. With your previous 3M Comply Sтерigauge product, it had more the teal and white color scheme, but now with this 3M A-Test product, it's the red and the green. Why the change?
So the change was made because based off of CSSD and OR manager feedback, they really needed something to be easier to interpret it. So the change was made to help with that interpretation. In addition to that, we also added print to the back of the chemical indicator so that it's easier to find in the event that it's flipped over in a tray.
Oh, nice. I'm sure that that's very helpful for operating room staff. So the standard has always been for both the 3M Comply Sterigauge product and now the new 3M A-Test chemical integrator. The standard for rejecting or accepting has always been it's crossed the line. Has anything changed with this new product?
There has been no change with this product. So it's still, as long as it is passing into that green accept area, it's considered an accept.
Okay, so if it's right on that line, right in the middle between the red and the green section, what does that mean?
So if it's right on that white line, it is going to be considered a fail. You want to make sure that it's always migrating into that green area, and then that would be considered an accept. Anything in that white and the red would be considered a fail.
Okay. Is there such thing as more sterile? Does more green mean more sterile? Or does less green mean that there may be an issue with your sterilizer equipment or sterilization cycle?
No. More green, less green is all the same as long as it's in the green. So if it's in the green, it's good.
Okay. When using a process challenge device or a PCD, what is the protocol when your biological indicator shows negative, but then your chemical integrator shows a failed result? What happens next?
This happens from time to time, and is actually addressed in an AAMI ST79, section 13.7.5, and also in figure 10. If you have a biological indicator that passes and a chemical indicator that fails, it is considered a fail, and the technician will have to redo the entire load. It's the same concept as if your biological failed and your chemical indicator passed. You would also then have to redo the load.
Okay, so you're looking for passes on both.
You're looking for passes on both, correct.
Okay. Does or should the proper placement of a PCD or process challenge device or a chemical indicator have any sort of impact on the pass rate of a chemical indicator?
Proper placement of your PCD or your process challenge device and your chemical indicators are essential to getting an accurate result. So staff want to make sure that they are placing their PCDs label side up on the front of their sterilizer cart over the drain, which is the most challenging part. And the same goes for chemical indicators. When you're using them in your tray, you want to make sure that you're placing them in the most challenging areas of that tray.
Kayla, thank you so much for sharing your insights about the new 3M A-Test chemical integrator product. You're a sterile processing technician at heart. I'm a sterile processing technician at heart, so it's been great to sit down and chat with you. It's great to meet you.
Thank you for having me, and it's nice to meet you as well.
All right. I am so excited to welcome our next speaker. Amanda Motter is a technical service specialist with 3M and provides global perioperative education. She has a Bachelor of Science in Nursing and graduated summa cum laude from the College of St. Scholastica here in Minnesota, also where I'm located today. As a former operating room nurse, she is a certified CNOR with clinical leadership experience as a specialty service leader and patient care provider or patient care supervisor. Amanda is going to talk about both the importance of our role in reducing the risk of cross-contamination and explain common risks that lead to surgical site infections. I am so excited for this next presentation, and I want to welcome Amanda Motter.
Hello, everyone, and welcome to Every Touchpoint Counts, Surgical Site Infection Risk Reduction. I'll be your speaker today. My name is Amanda Motter, and my disclosure is that I am an employee of 3M, and this presentation will be free from product reference and commercial bias. Surgical site infections are multifactorial complex events, and this webinar will journey through the entire patient process, explore the many touch points and key players the patient encounters, look at global research and explore what we do know about infections and the actions we should take to reduce their occurrence, and on conclusion, you'll better understand why the process doesn't start and stop when your patient is in your department, and why every touch point counts to reduce SSIs. All right, let's go on a journey. Imagine you're the patient. From start to finish, how many people do you contact along the way? And how many of those people have an impact? Here's a scenario. Miss Smith is a 70-year-old female who presents to her orthopedic surgeon's office complaining about her knee pain. Her history is significant for, arthritis, hypertension, diabetes. She's had several injections that gave her a bit of relief in the beginning, but the last one she reported no pain relief. So her doctor does a physical exam, looks at her images, recommends a total knee. A month later, she has her knee replaced. The surgery went well. The staff followed protocol. There were no complications, and she was discharged. But within 6 weeks at home, she notices her wound is not healing as quickly as she feels it should. There's thick, yellow, foul-smelling drainage coming from her incision, and it's red and painful to the touch. When she notices she has a temperature, she calls Dr. Lee's office. So I wish I could say that this scenario is rare, but it's not. From the patient's point of view, everything was fine, and then the infection happened. She may wonder, why me? What did I do? What went wrong? Is my doctor bad? These things, they're all relevant questions that many people ask. The problem with SSIs is that we often don't know the exact cause. They're really complex events. So in this webinar, we're really going to look through that entire process and all of those patients and what we do know. This is a conceptual map of a patient's journey through the healthcare process. It often begins in a clinic where she'll encounter a physician, PA, nurse practitioner, as well as an extended team of nurses and assistants. She may be sent in for lab work or other screening and diagnostics prior to her surgery. Many facilities have a pre-admit department where you get a call from an RN just to ensure that your patient is fully optimized. On admission, initial intake is performed, an additional day of screenings. In pre-op, a collaborative team of physicians, nurses, anesthesia folks prep the patient. She's transferred to the OR, where another very elaborate team of clinicians provide care. Think about perfusion, spinal cord monitoring, radiology, many others that collaborate with the core team. She's transferred again to either a recovery unit or inpatient unit consisting of nursing, medicine, rehab, therapies, pharmacy, dietary, just to name a few, before getting discharged. So now I cover this not only because you're unaware of the process or people, but because we want to highlight there are many different changes of hands and levels of care in all of the departments and people involved from beginning to end. This slide looks a bit like a subway map. It's really busy, I know, but that's kind of the point. This is a more in-depth look at the previous slide at all of the functions and roles impacting the patient, from people to services and equipment. Let's take a moment to look at the orange line. That's for equipment and materials. They're kind of the behind-the-scenes players all the way through. So bad cleaning practices and technique or even attitude can negatively impact many people, whereas conversely, best practices and diligence can go a long way. When we talk about all the touch points in each of these areas, these are the key players there. Hopefully I haven't forgotten anyone. This is not an exhaustive list. When I say RN, of course, that's staff, manager, director, infection preventionist, and any other specialized nurse. But as you can see, the list is quite extensive, from pre-op all the way through to home. Let's talk about some basics of surgical site infection. An SSI is an infection that occurs after surgery in the part of the body where the surgery took place. There are 3 types. Superficial, involving only skin and subcutaneous tissue of the incision. Deep, involving deeper tissues, as the name indicates, fascia, muscle, and organ space, involving any part of the body open or manipulated during the procedure, organs, or the implanted material. So this SSI classification occurs within 30 days of surgery or 90 days when an implant is involved. Some global organizations even say 1 year for implants, and we will discuss later other inclusion criteria for an infection diagnosis. But they are a global problem. Incidents vary among countries and procedures, but what we do know is the overall rates are much higher in low, middle-income countries and Southeast Asia compared to US, Europe, Australia. So let's take a closer look here at America. National average of SSI is about 2 to 5%. Rates are higher in clean contaminated and contaminated surgeries, of course. They're a huge burden on healthcare systems, providers, and patients. There are significant direct and indirect costs associated with SSIs. Direct costs are increased length of stay, readmission, additional interventions, nursing care, and treatment costs. For example, an average cost for an SSI is around $21,000. However, it can exceed up to $90,000 per infection when the SSI involves a prosthetic joint or implant or an antimicrobial resistant organism. So in the U.S., there can also be a loss of revenue from denied reimbursement because it's considered a hospital-acquired condition. So in terms of costs, we look at loss of productivity, patient satisfaction, litigation, but finally the most important impact is on the patient. And the impact on their life can be significant, at times life-threatening or even deadly. We know that up to 60% of SSIs are preventable, and rates have decreased modestly, but there's still work to be done. So just kind of a fun poll, you can answer this in your head. If you were asked right now to name at least 5 things you do in your current practice to prevent patients from infections, would you be able to answer that? How confidently could you say, yes, these are the 5 things I do every day to protect my patient? I could not answer that question. I could name 1 or 2, but I'd have to brainstorm. I would not be confident in my answers, or I'm somewhat confident, or D, I'm very confident. I could definitely name 5. So hopefully today we'll give you some confidence and some things that you can take with you into practice so that you can confidently say that, yes, here are the 5 things I do. But this graphic shows pathophysiological factors of an SSI. So infections are caused from either organisms from the patient introduced into the wound, essentially from the outside brought in, like a break in a sepsis. The other major cog is the response of the patient. Diminished general or local immune response of the patient can result in susceptibility, and it's important to note that we're exposed to bacteria and viruses all the time. 3 people exposed to the same bacteria may respond in 3 different ways. This is a conceptual formula that illustrates the complex biological process involved in determining the risk of developing an SSI. This states that the risk of SSI is determined by multiplying the dose of bacteria by the virulence or the strength of the bacteria, and then dividing it by the resistance of the patient. So our focus needs to be on the things that we can control. So we're going to add numbers to this and take a walkthrough. So the biggest thing to remember is that if your numerator is decreased or made smaller by lowering the amount of bacteria, then your risk number is lower. Also, if your denominator is higher or resistance is increased, as we will cover shortly, then the risk is also lower. So here we're going to give some arbitrary numbers to this. We'll just say 4. The number doesn't matter, but we have our dose of bacteria times how strong it is, divided by the resistance of the host, and all of these we're going to make equal. We'll say 4. So 4 times 4 equals 16, divided by 4 is 4. So our risk of SSI is 4. Okay, that doesn't mean much, but what we're going to look at here is now we're going to cut that dose of bacteria in half. So we're lowering that dose of bacteria to 2. So we have 2 times 4, 8, divided by 4. Now our risk is 2. So by reducing that dose of bacteria, we have reduced the risk of that patient getting an SSI. Also, if you increase the resistance of the host, which we'll talk about here, so increasing from 4 to 6, you can also reduce the resistance of the host. So now we have that same dose of bacteria, 2 times 4 divided by now 6, because you've increased the resistance that the patient can fight that off, and you lower your risk to 1. So variability and process can affect the dose the patient is exposed to. For example, did the patient bathe before being admitted? Did the nurse wash their hands before providing care? Was the room adequately cleaned after the last patient? These are all factors from the numerator in the equation we discussed. An important first step in SSI prevention is identification of patients deemed to be at higher risk. These risks per NICE, which is the National Institute for Healthcare and Excellence, state for age, anyone over 65, underlying illness would be an ASA over 3. They have significantly higher SSI incident. Specific conditions contributing to that also include diabetes, which is a 2 to 3-fold risk increase. You want to assure tight blood glucose levels preoperatively, A1Cs of less than 7%. Malnourishment will increase the incidence, as well as low serum albumin, cancer therapy within 90 days, and the use of systemic steroids. Also obesity, so anything over 35, because adipose tissue is not well perfused, and a good blood supply is needed to heal and fight off infection. We recommend smoking cessation within at least 30 days prior to surgery. Untreated peripheral vascular disease, because we need the tissues to be optimally perfused to heal properly. The actual operative site could put the patient at risk, because increased risk from sites like the groin due to the flora present in that area. Also, any previous or current skin infections. Longer surgical duration, extensive intraoperative techniques, wound contamination, obviously if you're bringing bacteria into that site. And the key is that you want to eliminate risk factors where possible. So things you can control. Advising the patient to quit smoking, making sure they're well nourished, if you're able to alter any medication or provide weight loss recommendations as well. APIC, which is the Association for Professionals in Infection Control and Epidemiology, simplified SSI risk factors into 4 categories. So this is kind of another way to look at the same information, but they say an SSI can occur through one or more of these interrelated factors. So it can be microbial, which centers around bacteria, how strong it is, and the resistance to the bacteria. Also host-related factors and comorbidities. Intraoperative factors, and post-op care related, which can adversely impact outcomes once a patient leaves the room. So now that we've reviewed and understood the basics of SSIs, we're going to revisit our patient process. Understanding really drives compliance. So if you're, for example, a pre-op nurse and your patient comes in and says, hey, I wanted to save you time, so I shaved my chest at home a couple days ago. It's best to understand why that's a problem and explain to the patient, and then collaborate with pre-op or the pre-admit clinics in their pre-op instructions and be able to notify the appropriate people or respond properly if something untoward happens along the way. Just for fun, another poll. So I want you to look through and select the organizations you're familiar with in your head as I say them. AORN, CDC, WHO, APIC, NICE, or none of the above. And we'll go through in more detail what these are as well. So when walking through the phases of care, I'll discuss guidelines and global recommendations from many organizations, but here's several of them. So if you're not familiar, I would encourage you to go online and read more into it. I'll include the links at the end of the presentation. And it's not at all an exhaustive list. In America, for example, many providers often look to their specialties. So American College of Surgeons, just to name a few, to look at for recommendations on practice. I'll use acronyms throughout the presentation, but AORN is the Association of Perioperative Nurses. You've probably heard that one. Center for Disease Control, Society of Healthcare Epidemiology, which is a US-based infection prevention organization. APIC, Association for Professionals in Infection Control, is a US-based infection prevention organization. Of course, World Health. NICE, the National Institute for Healthcare and Excellence, it's a UK-based guidance that's often referred to globally as well. APSIC is Asia Pacific Society of Infection Control. It's a multinational Asian-based IP guidelines. National Health and Medical Research Council is Australian-based. CRINCO is a Commission for Hospital Hygiene and Infection Prevention at German Robert Koch Institute. They develop guidelines for hygiene and IP guidelines as well. So if you don't live in Europe or Asia, still many of these organizations have great research recommendations, and there is a common thread, and they are all referenced globally. So it's nice to have at least some familiarity with them. So the patient's first step in our case study is for an elective procedure is to seek out a specialist or see their general practitioner if there's a concern. So this may be the place where the problem is noticed or addressed first time in non-elective situations. In the clinic, when meeting with a provider, NP, PA, or nurse, the key is to fully optimize that patient before surgery, knowing the risk factors and educating them on the importance of not smoking or losing weight, managing their diabetes. They'll walk through the process, discuss the risks and benefits, maybe recommend a class, explain what to expect about recovery. And sometimes even those pre-admit nurses will go over things like bathing, mupirocin intranasal use. Bathing is recommended preoperatively. The CDC, World Health, and NICE all recommend a bath or a shower with soap, antimicrobial or not, at least the day before or the day of surgery. And the CDC also discusses an antiseptic option. Once the patient gets admitted into pre-op on the day of surgery, it's the team's responsibility to increase the resistance of the patient, as we discussed in the previous slides, and to decrease the amount of bacteria the patient is exposed to. So a head and toe assessment, updated physical should be checked to ensure the patient has no other infections, no UTIs, cellulitis, etc. Check the skin. Any infection like that could decrease the patient's ability to fight and would burden their system. So we want to ensure bathing was done, or at least know your hospital's protocol if it's not. If you don't have a backup plan or protocol, talk to the necessary people or get IP and the leaders involved to create one. Shea recommends antibiotics within 1 hour of incision or 2 hours for Vanco. NICE states they should only be given in clean cases with implants, clean contaminated and contaminated surgeries. The CDC and World Health are a little vague. They state antibiotics should be used when indicated, and the CDC specifies use in C-sections, but state not to redose any clean and clean contaminated cases. Nasal decolonization, hair removal, and warming we'll discuss in upcoming slides. Shaving with razors causes microabrasions in the skin, which can create gateways for bacteria. All organizations recommend leaving hair in place. The presence of hair will not increase the risk for infection, so if hair removal is needed because it either interferes with the operation or dressings, or if the provider absolutely insists upon it, then it should be done as close to the time of surgery as possible outside of the OR. Only use a clipper with a single-use blade. Tissues heal most effectively in optimal conditions of oxygenation, perfusion, and body temperature. Inadvertent perioperative hypothermia is a common but preventable complication of perioperative procedure that is associated with increased risk of surgical site infection and other post-op complications. Active warming is recommended by many organizations, and active warming does not include warm cotton blankets. Those methods are not effective to maintain normothermia. So let me explain to you the temperature gradient in the human body and why it's important to begin this intervention in pre-op. You and I, as we sit here, our normal temperature is 37 Celsius or 98.6 Fahrenheit. That's our core temperature. So our body, through shunting of our arteriovenous system, likes to keep our periphery or our extremities 2 to 4 degrees Celsius cooler. Okay. The problem with that is once you're given a narcotic, general anesthetic, or regional block, our vascular system cannot maintain that shunting any longer. The vessels dilate and the cold peripheral blood circulates into our core, actually lowering the core body temperature. Once that happens, it's hard to reverse a hypothermic state. So by pre-warming, we're topically warming periphery, so there's no difference between the extremities and the skin and the core. Then, when dilation happens, temperature remains the same. So as you can see, warm for warm is circulated. Staphylococcus aureus is the leading cause of surgical site infections, and 30% of the population are carriers of Staph aureus in their nose. An interesting publication by Pearl out of the New England Journal of Medicine studied patients with SSIs who had samples from both nares and the surgical site, and they found that over 84% of Staph aureus strains isolated from the nares were identical to those isolated from the surgical site. So not that they were both only positive for Staph aureus, but they found that it was the same colony that infected the surgical site. The concept of how bacteria gets from the nares to the incision can be a bit confusing, but there are literal means of transportation. So unfortunately, people put their fingers in their nose and touch other things more than we would like to admit. But also, if you're colonized in your nares, that bacteria is part of your microbiome. It's probably also in your environment, and it can affect that way. Another theory is that the nose is a self-cleaning organism and it drains into the throat. So if microabrasions happen during intubation, then the bacteria could enter the bloodstream, and with a new incision, as your body increases blood flow to that site to repair, it can essentially infect from the inside out. But the truth of the matter is, at this time, we're not exactly sure how it happens. The CDC recommends for all high-risk patients, and that include those known to be Staph aureus carriers, those who are having cardiac or orthopedic procedures, and also patients in the ICU with a central line. In order to reduce the risk, they say to do a CHG wash or wipe as well as nasal decolonization, either using mupirocin or povidone iodine. Now, mupirocin is an antibiotic, must be administered pre-op twice a day for 5 days, which obviously sparks concern for patient compliance and antibiotic stewardship. The other alternative is iodine, which can be used immediately prior to surgery without any resistance concerns, and studies have shown it to be equally effective to mupirocin. World Health also recommends known carriers having cardiothoracic orthopedic surgery to undergo a mupirocin regimen. Asia Pacific also recommends that the known carriers having cardiac or ortho procedures to receive mupirocin with or without the CHG bathing. Additionally, Dr. Engelman and Dr. Aurora provided a commentary regarding the risk of routine swabbing and testing for Staph aureus, and discussed that it poses a risk to healthcare professionals during COVID-19 era. There's potential for increased risk of inadvertent transmission during the swabbing of these testing procedures. While clinical studies have demonstrated the effectiveness of povidone iodine use for pre-op and nasal decolonization, so the authors suggest that until evidence demonstrates differently, they suggest using routine nasal decolonization of urgent and emergent surgical patients to be done with the povidone iodine without pre-op testing to determine colonization. So instead of screening, just move to decolonization practice. Iodophor is an effective treatment, but also there's a benefit of a single dose, so it can be done day of. In this section, we'll talk about all the tests done before the patient actually enters the operating room. An important touch point before surgery that can't be downplayed is the staff and decontam, central sterilization, and our folks in housekeeping are those who are responsible for environmental cleaning. Their main goal is to reduce the dose of bacteria the patient is exposed to. While they're behind the scenes, so to speak, their roles are critical to patient safety. So you may have heard news about facilities that had mishaps in sterilization and may have exposed numerous patients to infectious products. Obviously, very diligent practice can go a long way. So you can't always see biological residue. You can't always see biofilm or microbes. You can't see inside long, narrow lumens. So the first question you should be asking yourself is, why is cleaning such a big deal? The purpose of cleaning in a healthcare environment is to remove any soil that might be carrying pathogens or disease-causing organisms. If all you need is a pathogen to be killed, then why clean? Why not just disinfect or sterilize? So the point to understand here is that surfaces, instruments, endoscopes cannot be disinfected or sterilized if the surface is not clean. Soil protects pathogens from the action of disinfection and sterilization, allowing them to survive. Microbes that survive reprocessing have the potential to cause infection. So let's take a quick minute to review the differences between the processes. In cleaning, we discussed is removing the soil, allowing that disinfection and sterilization to occur. Disinfection is the process by which the microbes are killed, but it doesn't kill everything. Sterilization has a much greater kill power than disinfection and is more effective at killing spores. Sterilization is validated to 12 log reduction and has an overkill safety margin. By contrast, disinfection has lower and there's no overkill safety margin. But remember that cleaning is just the removal so that both can occur. Different markers can be used to monitor cleanliness. Visual markers like dust, dirt, scum, you can often see it, but there are microbial markers, for example, a culture that will indicate the presence or absence of a microbe, but also protein, carbohydrate, hemoglobin markers, and ATP. ATP stands for adenosine triphosphate. It's the molecule responsible for energy transfer in living cells, like microbes, body fluid secretions, etc. ATP-based methods measure bioluminescence, or the amount of light produced in a reaction of ATP and luciferin, to estimate the amount of residual ATP on cleaned equipment or the environment. The level of the marker indicates how much soil is on the surface. The results are immediate, quantitative, and objective. This may highlight missed or high-touch areas or gaps in practice that can be improved upon. Talking about cleaning and sterilization assurance, let's apply that to a real-life scenario. So I apologize, this may be more applicable to OR nurses or central sterilization staff, but if the question is relevant, play along. So you're preparing for a surgery and looking at the instrument pan. The tape on the wrapping has turned and now has black lines. You open the pan for the scrub tech, but the indicator inside has not turned, or the line is not in the acceptable range. What do? Do you use the instruments? The tape on the outside was acceptable. Do you ask the central sterilization staff if they attest that it was sterilized and it's acceptable to use? Do you send it back? These indicators show that the sterilization process was not adequate. What do you do? So the answer, as we'll discuss in more in depth in the following slide, should be C. You should send it back. The indicators show that the sterilization process was not adequate. While most sterilization processes have successful outcomes, sterilization is a complex undertaking. So various factors like human error, equipment malfunction, and variability in utilities or steam supply can lead to inconsistent processes and sterilization process failure. For this reason, a suite of monitoring tools, including physical monitors like sterilizer printer tape, chemical indicators, and biological indicators, are used as part of a comprehensive quality control program to monitor the effectiveness of the sterilization process. For visual confirmation that the pack or pan was exposed to the process, standards, so AMI, the Association of the Advancement of Medical Instrumentation, states every packaged item should have an external process indicator These do not provide information on the quality of the sterilization process. Standards also say you should place a chemical indicator inside every package. AORN states external and internal chemical indicators specific for the sterilization method should be used in each package. The internal chemical indicator should be read and interpreted, for example, color, migration, or other changes before the tray or items are placed on the sterile field. And biological indicators, which contain a known population of bacterial spores, are used to identify the lethality of the sterilization cycle. Steam and vaporized hydrogen peroxide sterilization cycles are both monitored using biological indicators containing spores of geobacillus, while ethylene oxide or EO sterilizers are monitored using biological indicators containing bacillus spores. We deliberately use bacteria that form spores which are more resistant to sterilizers. Monitoring frequency is determined by the national guidelines or standards. For reference, the World Health Organization recommends testing steam and hydrogen peroxide sterilizers a minimum of daily and testing every EO sterilization cycle. Healthcare professional compliance with optimal hand hygiene practices remain low in most settings. Global and local experts agree that hand hygiene is fundamental to a good infection prevention protocol. There's no shortage of evidence to support good hand hygiene. CDC, World Health, SHE, ABIC, AORN, they all offer literature and tools to support the practice and implementation. AORN says it well. Surgical hand antisepsis is the primary line of defense to protect the patient from pathogens on the hands of the perioperative team members, whereas gloves are the secondary line of defense. Due to risk of glove failure, the performance of surgical hand antisepsis is critical for the prevention of SSI. What many of us may not realize is that glove failure, holes in sterile gloves can occur in the manufacturing process, and there are actually acceptable quality levels for holes in surgical gloves. While we can correct and replace a glove when we know there's a hole or tear, we also need to prepare our hands the best we can for the time when we're not aware of a defect in our glove. So that's why antisepsis is critical as a primary line of defense. In addition, all global organizations agree to prohibit jewelry, artificial nails, and many local organizations and facilities expand not only to OR care providers, but to include all care providers. Let's explore the options for pre-surgical hand antisepsis. There's water-aided options such as soap and water, iodine, or CHG soap. The mechanical action associated with hand scrubbing removes debris and microorganisms. However, mechanical scrubbing has a negative impact on skin health. Frequent hand washing and scrubbing with antimicrobial agents and scrub brushes can cause dry, scaly, cracked skin, which for some can result in severe cases of dermatitis. Did you know that AORN's guidelines for perioperative practice, they actually say that surgical hand scrub should not be performed using a brush for those very reasons? Some global guidelines, however, such as NICE, still recommend an aqueous wash with the brush first and approve an alcohol rub subsequently. In the 90s, leave-on products were introduced as single-active alcohol-based solutions. At the time, they were not well accepted because formulations were mostly alcohol and glycerin, which is hard on the skin and provides no lasting antisepsis. Dual actives were first introduced in 2001, and the combination of CHG and alcohol. The immediate antimicrobial effect of alcohol was enhanced with the persistence and cumulative effect of CHG. In addition, emollients were added to the formulation to address the harsh drying effect of alcohol alone. Asia Pacific Society of Infection Control and WHO both recommend an alcohol-based rub in places where water quality may not be assured, but that's not much of a concern in the U.S. That's more of a global consideration. This study is a good illustration of persistence. The baseline graphic shows a plated, untreated hand and all the bacteria that has colonized. The slides on the right look at three different options: CHG and alcohol, 80% alcohol alone, and 70% alcohol alone. And it shows that plated bacteria immediately after use and 15 minutes after touching surfaces to determine persistent activity of products on transient bacteria. The CHG and alcohol products showed persistence superior to the 2 alcohol-only products tested. So it confirms what we know about alcohol, which is that it has immediate kill but very little persistence. Now onto Intraop. The main goal of those involved in the Intraop phase is to once again decrease the dose of bacteria exposure and support the patient's defenses. In this time period, normothermia continues, although we won't go into any more detail. We will discuss surgical site prep, sterile surface and closure. Other topics that are often part of an SSI bundle that we will discuss include the use of wound protectors and clean closure trays. For the intraoperative phase, we'll start out with skin prep. So the goal of a surgical skin prep is to reduce the number of potential pathogens naturally living on the skin and to limit their growth during and after surgery. In the U.S., alcohol in combination with CHG or iodine is the most common. They work in different ways, so mixing the two can potentiate their effects. There are often conflicting meta-analysis stating one works better than the other. The global guidelines are mixed. They do all agree that it should be alcohol-based. So typically the surgeon will have a preference as to what prep is used for a specific surgery. However, it's important that we as healthcare practitioners have a solid understanding of the baseline considerations for prep solutions so that we can identify when it's necessary to change the prep and to keep the patient safe. We also want to be aware of application and dry times, read the manufacturer's instructions for use, and also know the prep area and the correct number of applicators that should be used. Surgical preps reduce the number of microbes on the skin, but they don't eliminate all of them. Skin on living people cannot be sterilized. There's always residual microbes that survive on the skin surface, in the deeper layers and the hair follicles. Without additional protection, these microbes can be picked up and transferred into the incision by items that touch the skin during surgery, which include gloves, instruments, sponges, saline, body fluid, which can also wash preps off the skin. The concept of an incised drape is to help prevent contamination, create an actual sterile surface all the way to the wound edge, decreasing the risk of residual microbes being transferred into the incision. That's one great reason why orthopedics have made incise use standard of care for total joints, not only because it makes the drape stick in place, which is nice, but the incise drape is 100% sterile, so they know that as they grab the limb to manipulate, it's what they're touching with their gloves is sterile, and they're not contaminating their high-risk operation. So to elaborate on this, you scrub your hands before surgery, but you still put on sterile gloves, not only to protect you, but to protect the patient. You would not dream of scrubbing your hands and setting up your back table with bare hands, no gloves. So apply the same standard to the patient's skin. We prep to reduce microbial count as much as possible, and then we apply a sterile protective layer. Guidelines on the use of incised drapes are conflicting. However, some new updated guidelines to distinguish between the benefits of antimicrobial and non-antimicrobial incised drapes recommend antimicrobial incised drapes use where indicated. Other intra-op topics of concern in SSI prevention include irrigation use, closure recommendations, and use of wound protectors. Wound retractors facilitate in retraction of the incision during surgery and also play a role in reducing wound edge contamination in abdominal surgeries. Shea, APIC, Asia Pacific, and numerous local agencies all recommend impervious wound protectors for gastric and biliary surgeries. Up to 97% of surgeons perform some type of wound irrigation during surgery. In World Health Guidelines, povidone iodine was more effective than saline, and they weakly recommend using it before closure. NICE and CDC say not to use antibiotic irrigation, but noted iodine may be used in certain cases. So consideration should be made on using a sterile solution no matter what the irrigation type is. You may also have seen vancomycin powder used, for example, in spines for SSI reduction. However, with concerns on resistance and conflicting meta-analysis, CDC, NICE, and Asia Pacific do not recommend this. Finally, for closure, surgical wound assessment and management found that the use of triclosan-coated suture reduced SSIs from 138 to 39 instances per 1,000 procedures. CDC and NICE also agree, but SHEA does not. If the wound is clean, topical antibiotic ointment has little benefit. If infected or contaminated, then it may be used. As far as clean closure trays for bowel cases, there's not a lot of global guidance on this recommendation to reduce SSIs. WHO does state that they do not recommend based on the fact that there is insufficient evidence. However, this is a common practice that you will see out in the real world. Now the patient is out of the sterile environment or even out of the hospital environment in our care, but how can we protect the site? Educate, educate, educate. So explain the how and the why. After their operation, wound hygiene is critical. Post-op dressing guidelines are vague and vary among organizations. Some surgeons' preferences are based on how they're trained. A Cochrane review published in 2011 on the use of dressings to prevent surgical site infections lists the criteria of an ideal wound dressing as having the ability to absorb and contain exudate without leaking or strike through, does not leave particulate contaminants behind, provides thermal insulation, is impermeable to water and bacteria, and is suitable for use with sutures or staples. The ideal dressing would also be atraumatic with removal, require minimal changing, provide pain relief, as well as be discreet and comfortable for the patient. With such minimal guidance regarding post-op dressing selection, it's helpful to turn the evidence-based knowledge we have regarding caring for chronic wounds. The primary goal of dressing in both types of wounds is similar to protect the wound bed from the outside contaminants such as bacteria and microbes, as well as contaminated body fluids. Voice of customer has told us that gauze and tape is used about 40% of the time for immediate post-op dressings. Gauze has a long tradition. It's familiar and readily available. It's perceived as being very inexpensive. It's conformable. It can be easily tailored to any shape. So there are some cons, of course, pros and cons to everything. Clinical evidence suggests that gauze dressings impair wound healing by lowering the temperature similar to that of open or uncovered wounds. The gauze dries easily and becomes adhered to the wound bed upon removal, causing re-injury, potential bleeding, and is painful for the patients. Studies have also shown higher infection rates in wounds covered with gauze dressing versus wounds dressings with a transparent film. An in vitro study demonstrated that bacteria can pass through up to 64 layers of dry gauze because gauze dressings do not present a barrier to bacteria. Many practitioners are unaware of the array of advanced dressing products available and the way they work. Film dressings generally require fewer dressing changes, which therefore affect the cost of care. Waterproof dressings keep the incision clean and protected from the outside and provide a barrier to contaminants. Silicone dressings contain a gentle adhesive for fragile skin, and antimicrobial dressings are an option when antimicrobial protection is desired. There's a newly emerging approach to managing closed incision as well called negative pressure wound therapy. And this in high-risk patients and procedures has shown clinical evidence to reduce surgical incision complications, reduce cost per patient, and decrease the incidence of SSI. It actively manages the surgical incision site, holding the edges together, removing fluid and infectious material, and acting as a barrier while delivering continuous negative pressure for up to 7 days. Post-op instructions are important. It's an important way to end the surgical care we provide. So patients should avoid touching wounds and dressings. Don't pick at sutures, staples, steri strips, or glue. Those things should either fall out naturally or sutures removed in the clinic if applicable. After 48 hours, patients should shower and wash with soap. It's essential to provide them with warning signs and directions for who to call if any of these are experienced. Surveillance should be done at a minimum of 30 days up to 1 year where implants are involved. Early diagnosis of infection allows clinicians to stop the spread of microorganisms, to adjust adjacent tissues, and to treat infections more efficiently. Post-op patients should assess for a feeling of tiredness. Now, this can be common in systemic infections. Also, low-grade fevers below 100 are common following surgery, but temperatures exceeding 101 can indicate infection. Clear or slightly yellow drainage is normal, but if that drainage becomes cloudy, green, foul-smelling, it can be a sign of infection. If there's increased or continual pain, that's a sign for concern. While pain from recovery is often common, it should subdue. If it fails to do so, an infection may be present. Redness is normal for healing wounds, but radiating streaks are often a sign of infection, as well as hot temperatures at the site of this incision can also be indicative of infection. Knowing what stage the infection process is at can aid in treatment. The early stages can be treated successfully. According to surgical wound assessment and management, superficial infections are usually caused by staphylococci and streptococci and can be treated with topicals like bacitracin or polymyxin, either alone or in combination with other antibiotics. If pus is present, treatment is necessary to drain the pus. Sutures, staples should be removed and tissue debrided in the case of necrosis. It's recommended to initiate antibiotics when inflammation reaches beyond 5 centimeters and includes pain, redness, increased temperature, edema, purulent drainage. Gram stains are recommended for appropriate antibiotic treatment, and for complicated, deep, non-healing wounds, negative pressure therapy should be considered. It facilitates blood supply to the wound by promoting angiogenesis and increase the rate of tissue reformation. Deep tissue infections are also treated with targeted oral or IV antibiotics. So we've gone over a lot of information, but to take it all away in real-life practice, I'm going to remind you here's some great global organizations to look into when researching for your evidence-based practice, whether you just want more info or are building bundles. When we talk about implementation, here's a great example of a best practice case scenario. A randomized clinical trial assessed whether improved basic preventative measures can reduce post-op staph transmission and surgical site infections. The study's nice because it looks at the entire process and many factors just beyond prepping or warming. The original study plan was powered for 1,000 patients instead of 236. However, the sample size provided power to reduce transmission rates from 40% to 28%. So in other words, even though the study size was not fulfilled, the results provided confidence that the implementation of the infection prevention bundle demonstrated a statistical difference versus care in reducing Staph aureus transmission. So this bundle had various things, for example, 70% hand hygiene, organizing a work area, separating that dirty and clean, improving environmental cleaning, disinfecting catheters, decolonizing the nares with povidone iodine, using a UVC light therapy to the OR environment, and then providing that feedback. And so as you can see, the results were a decreased number of transmitted Staph aureus isolates, as well as a decreased SSI rate of 1 in 106 in that bundle versus 10 out of 130 in the control group. Another example of implementation now with our current times for COVID consideration, Dr. Dexter took that infection prevention bundle and applied it to COVID. So while this is not SSI, it's very relevant for the times. So he thought if it helps SSI rate and decolonization, shouldn't we be treating all of our patients with it? So the key message is optimizing patient care in these times. This is an evidence-based approach to a protocol, not a study. But since modes of viral transmission are primary contact with contaminated environmental surfaces and aerosolization, recommendations focus on minimizing the risk of transmission of COVID to both patient and caregiver. The second graphic here discusses management such as staffing models for longer shifts, phase 1 recovery in the OR, and multimodal cleaning. So when implementing these, who's involved? Clinicians and staff that work in all areas of the hospital have a responsibility to ensure the safety of patients. So interdisciplinary teams should work collaboratively to identify best practices strategies for the prevention of SSIs. This should be followed with education and appropriate training to those that provide the care. Think total prevention policy. Any interaction you have with the patient is an opportunity for you to positively impact the patient's outcome and help reduce the risk. Our patients are depending on us to protect them. We all play a part, and every touch point counts. Here's a list of those global recommendations that I discussed earlier as far as Asia Pacific, CDC, World Health. If you'd like to go to any of these organizations to look up their guidelines on SSI prevention, I would encourage you to do so. That concludes the presentation. Thank you very much for your time today.
All right, Amanda, thank you so much for giving such great information to our audience tuned in today. We did have a lot of great questions that came through, so I am going to just get right into it. We have about 5 minutes to get through as many as we can, so let's see what we can do. All right. Let's see. So the first question that came through, what are your thoughts on nasal decolonization with alcohol-saturated swabs?
Yeah, thank you. So I think one big important thing when you're looking at practice is to look over the global guidelines. So like the presentation said, really look at, World Health, CDC, SHE, what do they say? Because they really do an all-inclusive look at the studies and the research behind all that. So in the presentation, I talked specifically about the CDC. They have the most recent recommendations. Last fall, I believe, they updated for recommending either mupirocin or povidone iodine for nasal decolonization. And World Health really kind of follows suit with that. They talk about mupirocin use, and Asia Pacific talks about either mupirocin with or without a CHG bath. But none of the alcohol use. So I would really kind of caution, if you're thinking about something like that, to really look over the evidence and the studies behind a product like that. And like I said, you can look to World Health, and they really talk about what studies did we look at, how did CDC make their recommendations for those specific products, and why, and what studies they analyzed specific to those.
Okay, thank you so much. When everything is followed according to standard and very strict precautions are adopted, and then there is an infection, what will be the reason behind that?
Yeah, that's a good question. It's frustrating. Sometimes we don't really know what causes these things. It can take as few as 10 microbes per square centimeter to cause an SSI. And like we said, 3 people can react to the same microbes in 3 different ways. So we never really know. We can do everything right. Everybody plays an important part, and we can do everything right along the way. But you can end up with an infection. So, another big thing to think about is we have our controlled environment, and we have our sterile technique and our best practices, and we have no obvious breach in anything. But what happens once the patient goes home and they're out of that environment and out of that control? Are they keeping their dressing covered? What does their home environment look like? How often do they clean their sheets and things that are touching any potentially open incision too? And sometimes it's really hard to pinpoint those things, but we really have to just try our best to do everything we can. And sometimes we can't say exactly what it is, but.
Okay. Can you elaborate on anesthesia's role in surgical site infection prevention?
Yeah, absolutely. Anesthesia plays a big part in this as well. One big thing is just increasing the resistance of the host. So we talk about, in the guidelines, they also go deeper into like O2 saturations and blood sugar control and things like that, which will help with SSI. But another big thing they do, not only controlling the environment, making sure who comes into the room is controlled and things like that, but they do a big part in normothermia and making sure the patient is warm. We know that when a patient is warm, they can fight off an infection better. And they're really the gatekeepers of that, controlling the temperature of the patient and making sure that they're set up for success that way.
Okay. What about double gloving? Should we have this in our protocols?
Yeah, that's a good question. Interestingly enough, gloving is not something that the global guidelines, so World Health, CDC, et cetera, not something they really look at for a specific practice for the purpose of reducing SSI, but it's definitely something guidelines look at. So ARN, for example, has recommendations on it and does recommend it based on studies. But the broader guidelines, those CDC or Asia Pacific or NICE and those kind of things, don't talk about it specifically, but you can go, there is research on it, and you can go to, like I said, ARN, which does recommend double gloving.
Okay. This next question says, it's been a minute since I've been in the OR. Have hospitals stopped using powdered gloves in the OR? What kind of gloves are recommended?
Oh, I guess I can't speak for all of them if anybody's still using that. Like I said, for the last one, the recommendations for globally don't get down to specifics on gloves or double gloving or what types of glove you're using. But specific ones do. So I'm trying to think from AORN guidelines if they talk about those at all. And I don't believe they do. It might be kind of an older practice. But I guess I would encourage maybe to look at some of those smaller local guidelines like AORN and really see about any research behind that specifically.
Okay. This next question, laminar airflow is laminar airflow effective in controlling the risk of SSI in ortho cases?
Oh, yes. And I'm trying to recall.
For anyone wondering what laminar airflow is, it's air moving at the same speed and in the same direction with no or minimal crossover of air streams.
Yes. And I'm trying to recall what the guidelines said on that. I believe World Health has some guidelines on that as well. And I would actually ask, I'm going to push that to one to my inbox, and I will look it up for you and I will get back to you on email.
Wonderful. We had multiple people write in saying, great presentation. Thank you so much. We are out of time for this session. Amanda, thank you so much for sharing such great information, such important
Thank you for having me.
information. Absolutely. We look forward to hopefully having you at another Beyond Clean virtual event. If anyone has additional questions for Amanda, feel free to reach out to her directly. Her contact information can be found in the speaker bio tool on the right-hand side of your screen. Just another reminder, we do have a 15-minute break before the next session. So take a little walk, grab a coffee, grab some water. Hydration is important. And we'll see you guys back here in the next 15 minutes. Thank you so much.
Thanks, Lindsay.